Wakefield community. It's not every day that I get to introduce a friend of 50 years. Brian and I first met each other in the 9th grade, riding bikes in front of our homes in Charlottesville, Virginia. The next year, we attended the same high school. So Wakefield students, the lesson to be learned is simple. Make friends early in life and keep them close for the duration. Almost nothing is as rewarding as a long and durable friendship. And the older you get, the harder it is to make new friends. Brian is an exceptional person and an exceptional doctor. Not only does he work very long hours and take call for pediatric orthopedic cases in his regular life, but one or more times a year, he travels to greatly underprivileged nations, such as Mozambique, Ghana, Ecuador, and Guatemala, where for up to a week at a time, he works as a volunteer, nearly nonstop, performing surgery on children to correct orthopedic birth defects, deformities, and injuries. His wife, Lisa, who is a nurse, often accompanies him. Brian's charity work has a lasting and hugely positive transformational effect on youngsters' lives. Tonight is an opportunity to learn about healthcare in other nations and how fortunate we are to live in the United States. Now I turned it over to Stuart Ginsburg.
Thank you, Mr. Larner, and thank you everyone for attending this Wakefield Country Day School Adjunct Faculty Seminar. We're very pleased to present Dr. Brian Shaw speaking about operating a charity clinic in Guatemala. Of course, because this is Wakefield Country Day School, there are certain courtesies that we follow, and they follow us to Zoom as well. As I'm sure you expect, we'll collect our questions towards the end. And just like law school, when I teach a class on Zoom, if you can raise your electronic hand using the button at the bottom under the reactions button, or for those of you who need to find it, your hand will be raised on the list of participants, and I'll be able to call on you through that. And also, of course, as you know, let's try and keep ourselves on mute when we're not asking a question. So now, introducing Dr. Shaw is an interesting task. I asked him to send me his resume so I could learn a little bit about him. And he sent me this. So I thought I had a long resume. Dr. Shaw has a 22-page resume. It is the war and peace of resumes, I would say. So just picking out a couple of highlights, although the thing I'm most interested in for Dr. Shaw to speak about is what was Mr. Larner like as a student, as a high school student? But perhaps we better handle that offline another day. But inquiring minds do want to know.
I object.
Overruled. Dr. Shaw did his undergraduate work at Wesleyan University, which is one of the little three liberal arts schools, along with Williams, where I went, and Amherst, where Ms. Lindstrom's son went. And for those of you who don't know, other luminary alums besides Dr. Shaw from Wesleyan are Lin-Manuel Miranda of Hamilton fame and Bill Belichick of Super Bowl fame. He then went on to UVA Medical School, became a surgeon specializing in orthopedics, and perhaps early on, Dr. Shaw can speak some about orthopedics and give us an idea what it entails, and also the process of becoming an orthopedic surgeon. So at this point, it's my pleasure to turn the microphone over virtually to Dr. Brian Shaw.
Thank you, Stuart and Paul. Can you hear me, first of all?
Yes, you're coming through great.
Okay, and do you see my screen? Okay, you seeing it now? All right. Do you see a picture there?
We do.
Okay, you see this guy with the beard? The scruffy beard. This is your current headmaster. So you want to know what he's like. This is both of us. He influenced me a lot during those years. But your headmaster, when he's not bossing kids around and people around at Wakefield, he runs a nonprofit, helps run this nonprofit in Siem Reap, Cambodia. My wife has served, and he also he hays fields in Virginia with this guy. That's not me. Okay. I was influenced early on by my father. Is the biggest influence in my life right there, other than Paul. And he actually went to a country at that time called Ceylon, which is now Sri Lanka, an island nation south of India, and served on the Hope. And that was when I was about the age of many of your viewers in our early high school or middle school. I was very fascinated by him going halfway in there around the world doing surgery on this hospital ship, which has now been dismantled. That's how old that is. But very big influence. And so I thought I'd say a little bit about what a pediatric orthopedic surgeon is. Basically, what I do is I'm a doctor specializing in musculoskeletal conditions of children, teenagers, and young adults. And what we do is we use surgery, but also bracing, casting, medications, and physical therapy to treat our patients. And this takes 10 to 12 years after college. So it's a long time to train till you have to do 4 years of medical school, then what's called residency. And they call that because you're a resident of an institution. You go there and you live there. Now they're a little more relaxed. They like you to go home every couple of days, which is kind of weak. But we went and lived there for a couple of years, ate and drank everything in the hospital. And then you do what's called a fellowship, which is even more training. And then you have to take a very big test every 10 years to certify and recertify in this. So that's what we do. And that's what a pediatric orthopedic surgeon is. But we're mostly interested in these things, big bones and what's around them. So I've been fortunate to learn lessons traveling all around the world. These are all the places I've been. But I spent 14 years in Fresno, and you guys are near Appalachia. But this is the Appalachia in the West, and far ways worse, very poor. And California's Central Valley, where we grow a lot of crops, but we need people to work those farms, and that's what they do. And got a lot of training there. But then I thought, well, let's try to extend this a little further. So I've been able to travel around the world, serve others, but also do something that I like a lot, which is fixing bones. And it's also been very educational. And I've had very variety of experiences. I'm going to focus mostly on our work in Guatemala, but been in these other places, and it's very variable in terms of what you encounter. Here in Guatemala, we have a very modern operating room. You see, my assistant's here, and there's an anesthesiologist with modern equipment and a nice clean OR. But we've also worked in these places. This is the operating room. We have birds and bats and flies flying in and out of the operating room, and there's no air conditioning trying to work in there. So a lot of different places. Here's a limited, we call very limited resource environments, a very poor country with very poor public hospital. You can see these are the conditions. I'll show you a short video. Let me know if this doesn't come through. So that kind of gives you a flavor, and they cut this grass with scissors. So why don't they use a lawnmower? They could afford that. They said, well, because that would put 20 people out of work. So 20 people with scissors cut the grass instead of one person with a lawnmower. These trips require a lot of preparation and a lot of equipment. If we're going to go abroad and do surgery in limited resource environments, we need to bring everything with us. This is all of our stuff. Oftentimes, the airlines will donate at least one-way baggage, so it keeps our costs down. And when we get to places, this is when we arrived in Guayaquil, Ecuador a few years ago. There's often some publicity, but we're never really sure who's going to show up. So to our horror, we pulled up and there were people lined around the block and for several more blocks waiting for medical care. And we were there for a week and we couldn't possibly care for all these people. Now, these are families, so not everyone's a potential patient, but it was kind of heartbreaking. We had to send a doctor and a nurse through this line, and they had to kind of pick out who we could help and who we couldn't and send the others home. And some of them traveled all day or several days to get there. So you never really know who's going to show up. And when they do show up in these countries, it's not like here. They don't have medical records with them. We don't really know what's going on. We have to figure it out. So this is another place we showed up. They asked us to go when we were there in Kenya to go to this school. And then what they call a school isn't like the Wakefield Country Day School. They send kids who are disabled, and they may have perfectly good brains, but they have disabilities. And so they send them away from their families, and they live in these in an orphanage place where the conditions aren't very good.
Let me see. Stop at me. Hey. Hello. Hello, buddy.
And he's perfectly capable of walking with a minor surgery. These kids, very minor surgeries, but they don't have the opportunity to have it. So they crawl. And with very, very minimal intervention, we're able to pick children out from there to help. But it's pretty appalling, some of these conditions that you run into, not like here. So when we go overseas or go to a limited resource environment, we don't have, like we have in the United States, a safety net environment. Like we have all these medications and technology to help us. And if we don't get it right, maybe we can do it a little bit later, do a little bit at a time. So we start with very simple surgeries. We have to assume that children aren't healthy. Their baseline, they're often malnourished. They often have all these what we call comorbidities. They may have HIV or AIDS, malaria, sickle cell anemia, tuberculosis, other things that they don't know they have. So we have to be very careful. We can't just assume they're healthy and do an operation. So the anesthetic may be very risky. We pick surgeries that are simpler than this. This is a complex surgery even at home. So we wouldn't do that initially in this type of environment. The other thing we learned early on, or I learned on, is cast. You see this cast here. This girl's been casted, and she came back in a few days, and the cast is dissolved. So we can't use plaster, which has been used since the Egyptian days for bone setting, because it dissolves and melts in the humid environment. But we also have trouble with fiberglass, which is what most of you would get if you broke a bone, or we would get today, because even in that environment where they don't have furniture and they're crawling around on a floor or rocks, they can break down fiberglass casts very quickly. But one good thing about these kids is that they have very good immune systems, so that you can see here, we took this boy's cast off 6 weeks later, and here's his incision, but it's not infected. So many of them have a natural immunity. In fact, if you survive to age 1 or 2 years in these countries, often they don't name their children because they're not sure they're going to make it that long. That if they do, then they have very good immune system. Wherever we go, it's very important for us to take care of ourselves and our team members for certain diseases that are prevalent in that area. So we have to do homework, maybe visit a travel clinic and find out what's there so we can protect ourselves. This is one area we've been to a few times, and you see that very dark color represents the highest incidence or prevalence of malaria in the world. And this is right where we're going to be. So it's very important that we take our medications, and our team takes medications to prevent us from getting malaria when we're there. It's also important to watch what you eat and drink. You just can't go ahead and eat any food or drink any liquid unless you're sure it's safe. And this one of our nurses was very sick a few days into it, and we're not sure how she got sick, but so we don't want to become part of the problem and add to the stress of the environment there by becoming patients ourselves. But we're prepared to treat team members and others the same medically to restore health. One of the things that's important if you're going to serve on one of these trips, or if you're going to any part of the world that's maybe not considered a regular tourist place, is to check with the State Department. The United States State Department offers a free program called STEP, Smart Traveler Enrollment Program. It's free. You go onto this website, and what it does is it helps the United States Embassy contact you. You leave emergency numbers wherever you are. If there's a natural disaster or civil unrest or a family emergency, but also they can help family and friends get in touch with you in an emergency there. So this is just an example. As I was preparing this talk last week, Guatemala, where we've gone 10 years in a row now, is having a lot of volcanic activity right now. So the State Department set out an alert February 14th, and this is taken by one of our team members down there of the volcano going off, and the 7 surrounding villages, there are rocks as big as small automobiles falling in their villages. And so we needed to know about that. And then this is the volcano that occurred down there that unfortunately went right through a village last year, right after we left, and they used our supplies. We leave surplus supplies, so they're able to use our supplies to help those who survive this terrible catastrophe. So it's very important to watch out for team members and know where you're going. The other thing is very important is that we learned a hard way is to not skimp on our interpreters. So we went to Guatemala and we assumed that most people there would speak Spanish because the Spaniards settled that part of the world early on, but there's some indigenous areas where they speak other languages and not even Spanish or English at all. So we sent a team in, a sub-team. This is our team here in the hospital. We sent a few in to help them because they cook indoors and they have terrible lung disease. They don't have any ventilation. So we had these little stoves they could cook on that were very inexpensive, that wouldn't create so much smoke. But they thought we were there for this. They're gold. There's gold reserves there. And they had been taken advantage by gold miners before. So anyway, our team they held them there for a while with machetes and guns until we called the State Department, they called the embassy, and they sent in the army to free up our people. So when we go, we're like Doctors Without Borders. We're a smaller organization. We don't carry weapons, okay? But we do is take people. This is him. This is my physician assistant. And he's been with me for 10 years. This is him 10 years ago or 15 years ago in Afghanistan, but we don't take weapons. But he helps us with security and what we call situational awareness. No matter where you are in the world, in the United States or something, you need to know where you are and what's going on around you. It's just a good way to live, without becoming paranoid. But we need to know what's going on. And we've had things going on around us that we prefer not to be part of. So what you will encounter, and what we do encounter in these trips, is austere conditions, which can be very disturbing if you're not used to it. But this is a typical hospital room in a government-run hospital in Africa. And you see, these are the mothers here, mothers and fathers, and they have to sleep on this hard floor at night underneath the bed. And they'll put 2 or 3 children, unrelated, just patients, in these beds. And there, the nurses don't provide nursing care like they would here in the United States. The family has to provide that. So mothers will bring in food, a change of sheets, do all the bathing. That's done by your family. And if you don't have family, it's a big trouble. It's a big problem. These conditions are very difficult. You see a chair, you wouldn't find a chair like this at home or in your school. The wheelchair's missing wheels. There's water coming through the ceiling. Very difficult conditions. And this is the hospital. Likewise, where we work in the operating room, it's very hot. There's no air conditioning, very noisy, humid. We have to try to be as sterile as we can. But then we even had chickens coming in, or outside roosters, adding to the noise. I hit some of these slides, but they're still showing. Anyway, let's go to the slide. If I can get to that view there. Okay. So the conditions for living also, if you're going to go and participate as a volunteer, you put up with something like this too. This is the staff restroom, not the best conditions. So just a few points here about global medicine in general and surgery. In the United States, if you had a bad accident, an injury, you would take it to a hospital, or an ambulance would take you to the hospital. In a lot of these countries, they don't even have an ambulance service. You have to rely on somebody coming to get you or taking you to the hospital. But for 5 billion or 70% of the world, there is not safe and affordable surgical and anesthesia care access. You can't get it at any price. They just don't have it. And that's how we're fortunate to be part here. In the United States, each one of these figures represents 1,000 people. So I'm an orthopedic surgeon. We have an orthopedic surgeon for every 11,000 Americans, okay? So if you need to see an orthopedic surgeon, you can get in to see one immediately for emergency or within a few days or a week or two for non-emergency. Now imagine you live in one of these other countries. Each one of these figures represents 1,000 people. One orthopedic surgery for over 1 million people, okay? Another way of looking at this and understanding what's happening in the world outside the Western world where we are lucky to live is if you put tuberculosis, malaria, and HIV/AIDS all together and looked at how many people died of those conditions every year versus how many people die of trauma. And trauma is just a fancy word for injury, okay? Injuries. This is how many people die every year compared to all three of these combined. It's far more important, but you wouldn't know that from reading what you read. You hear about all these fancy diseases and they're very, very important, not to diminish it. But most of the money goes here, very little money goes here, and that's why we do what we do. I'll give you an example. This is a 19-year-old woman. You see her ankle, it's stuck like this. It doesn't move because she broke it a few months earlier. This is her x-rays. She broke it here and here, and it healed like that. It healed like this in 6 months. She came to us wondering if we could fix it. In the United States, this would be so simple. If somebody did this commonly stepping off a curve or playing soccer or some sport, you'd go to the hospital, you'd fix it, and you'd be fine by this time, back to doing your normal life. But there, it's a big problem. And if she supports a family, she can't work. It's a disaster. Likewise, this gentleman was riding a motorcycle and a donkey ran in the road. He hit the donkey and broke his femur right here, broke it here, and it came out through the skin. And this is his femur, his x-ray 3 months later. He's in traction. This is a bucket of water tied here. And he's just laying there for 3 months. Here at home, that night or the next day, we would get fixed and you'd be walking on this the next day, walking on your fixed broken femur. Here, 3 months in the hospital, not healing, no future. Similarly, this 21-year-old woman was carrying a water bucket on her head and she fell. And now the water was in a bucket attached to her hip for traction for her leg, and the hip is out of the socket. It's supposed to be here. So this, she would have been treated in a 10-minute procedure anywhere in the Western world. But there, she's 7 weeks in the hospital, no prospect of anything happening. And we fixed her. But this is the difference. How surgery can fight global poverty. Most people think it's way too expensive. If you're going to do surgery there, it's way too expensive, but really it's a great value. And the problem is building the infrastructure. You need to have infrastructure and buildings and sterilization process. It's easier to go vaccinate and provide medications. But if you improve the surgical infrastructure and build the infrastructure, it strengthens the entire system. One thing we do is when we go anywhere, it's very important as a tourist or as well as a medical volunteer to respect local customs and culture. And this is a representation of naive or native art. Maybe you'll study that in school where the artist doesn't really go to a professional art school. They just learn it and they have some talent and skill. And this is a visualization depicting traditional medicine in Guatemala. I only have one bad slide. Maybe this one may be a little disturbing, but this boy worked around heavy machinery. In the United States, that's against the law. You can't have children working in factories. There's child labor laws. But over there, they do that or they starve, or the family starve. He got his arm caught in a machine. And this hand, his fingers here, there's nothing that's useful. They're alive, but they don't move. He can't move them. He can't feel them. But there they were very proud. They made this contraption and they saved his extremity. But the problem, I said, why did you do that? He's been in the hospital for 2 months. He's never going to work. His hand will never work. He said, well, their amputations are taboo. They're not acceptable. So we have to respect the culture. A common condition we treat around the world is called Blouse disease. I'll show you a video here. You can see how this man is walking. He's 18 years old. He looks older. But this is a very bad case of bow legs, and it's very common. And this is a picture of him again. This is how we fix it. His x-ray is like this. So we cut the bone here and put some pins in it. The problem we have, though, is with a lot of places we don't have good follow-up care, which is not acceptable. We need to know how he's doing to make sure he rehabilitates and recovers from that. Another problem that we encounter in a lot of these places is bureaucracy and corruption. That you can't escape it. This is just one location, Africa. I thought this was the locked ward for maybe the psychiatric patients or criminal patients, but no, they lock all the patients in the wards till they pay their bill, and then they leave. So as you're thinking about maybe volunteering for any type of organization, you might think about private versus public. There is a case to be made. You're in a private school, not a public school. There's certain reasons your parents are sending you there. And likewise, private enterprises may be able to minimize corruption better than government ones. That's been our experience. Let me just check, because Paul told me he was going to come all the way to Colorado and kill me if I went overtime. So now that I'm on this, I can't see my watch. So sorry, Paul.
4:30.
4:30. Okay.
You got some extra time.
Okay. Okay. All right. So this is probably, as a pediatric orthopedic surgeon under 18, this is probably the most common thing that we treat. And these are called club feet. Okay. And in this country, you would never see a person like this. You would never, in the whole United States and the whole Western world and Europe, you would not see a child 10 or 11 like this. But there, they don't, because we treat you as an infant before you would even know it. We treat it, and we can't 100% cure, but we can make it so you would never know somebody had club feet. But now, when we go, we see a lot of patients with these neglected club feet where their feet are basically upside down. This is how they walk. Okay. And here's more. So these are younger children, little babies, toddlers with club feet. And you can see already starting to walk on the size of his feet. And what we do when we go there, which gives us great pleasure and satisfaction, to do a fairly simple operation and correct these club feet, and then put them in the nice cast to hold them until it's healed. So that's a very common thing. Some club feet are easier to fix than others. This is a teenager, 12-year-old girl. And you see, this is the x-ray of what her club foot. And because she's been walking on her foot, on top, there's a callus, which is most people have calluses on the bottom of their feet. Well, when you walk on the top, you get this rough callus here. And then through 2 little incisions, very small operation, we're able to completely correct the foot. This is in the operating room, so the callus is on top. And this is just tremendous. So we're able to provide the service at very low cost, very easily. When they're older and they have very bad club feet like this, it gets more complicated. You see, this looks like a little bit like a jigsaw puzzle. We cut out wedges of bone and put the feet straight. This is a little more complicated. But instead of going there and just doing the surgeon, and I'm sure you've all heard, it's better to teach a man how to fish than to catch the fish and provide the fish. So that's one of our goals. Wherever we go, we want to find out who's locally. So this is one of our local surgeons in Ghana that we work with. And I taught him how to do this operation. And now he's able to provide the surgery there for some of the children. And here's after. So this is her before, and this is her after. This is back in Guatemala. There's something called brittle bone disease, which also occurs in the United States. We don't have a cure for it, but we can treat it. See, this is her knee joints, and then she has extra joints below her, between her knees and ankles, and extra, because her bones are broken there so many times, they're bent there, but we're able to straighten them out and put her in a cast. So she sees that there's giving us a little thumbs up right there. This is her father. So again, when we go to these countries, we have to be very respectful. Her father never had an opportunity to have surgery, but look what he figured out. This is how he gets around.
Good morning.
My name is Vitelio, papá de Katy Bautista. Ese es especial niña, mi hija especial.
Sí.
Gracias por ayudarme y ayudar a mi hija Katy, que Dios les bendiga. Y nosotros que siguen adelante, nos han cambiado la vida. Estamos muy contentos y felices por eso.
So he's thanking us for our service. This is the hospital we go to in Guatemala. And this is how he gets on with gloves, his hands, and a skateboard. Sometimes we don't have an answer for everything. So you can see this youngster. I don't even know if there's a name for this. If it is, I don't know. And sometimes it's just best to leave kids alone. We have to be respectful of the ingenuity there. Look at this man. He walks on his knees. He doesn't have feet. So he has sneakers he wears backwards. And he has a hand-powered bicycle that was rigged up there. See the pedals? Go for his hands. And again, it's very, very important to be respectful. Even things you may disagree with, like not being able to amputate. But people are proud. You have to respect their culture and their opinions and have good translators or interpreters. As a volunteer, you must be flexible and adaptable. The most important thing is to have an attitude of humility. We don't go there saying, here's all the answers. We go there and say, what do you need? What can we provide? What can we teach? And then I like to say, and it's not just me, but when you get into surgery and spending many years to it, you understand it's a team sport. No surgeon can work alone. We require equipment, we require skilled staff to help us. And the more complicated the problem, the more skilled people we need here and abroad around us to support our work. So why do we do it? Why do we do this work? In the last 5 minutes here, it's very, very gratifying. This youngster, she had a club foot. You can see her scar. And this picture was sent to me 6 weeks later by our local surgeon. And we corrected her foot. But we had a little time left over, and this man was he worked for the whole family, his daughter, the whole family, supported his parents and kids. And then he had broken his leg on a motorcycle, and they'd done 2 unsuccessful operations. I said, well, we can amputate, but again, he wouldn't accept it. He said, operate. I said, it won't work. He said, operate. So we did. And here he is 6 weeks later, and it worked, and he's got a leg now. And this girl came to us from the people that actually held our people hostage before. And because we had reached an understanding with them, they said, don't worry about that. Can you come fix our people? So we did. So why volunteer? Here's a good thing you want to keep in mind as you're going through school and trying to decide on a career. If you work at something you love, you'll never work a day in your life. And it's not completely true, but there's a lot of truth in it. So you can minimize your work, the things you don't like about your work, and maximize the things you do like about it by remembering this. And as doctors, we have to think that we took an oath. And the first thing is first do no harm. So when we go to places, we need to make sure that we're not creating more problems, like not doing anything too fancy or not doing anything that can't be undone or fixed by the local surgeons. It's very important to understand that. And the other thing is life is short and the art is long. So it took me, 4 years of college, 4 years of medical school, 10 years of training after that approximately. And then you have to your 60s till you're done. I'm 64. I'm not sure how much longer I can do this. So life is short. The art is long. It takes a long time to get proficient at something like this. You want to make the most of it. So that's the balance, is striking the balance between education and working. And you can do all these things. And I've been very lucky. And then also I still learn. So I'm always being educated. When you're a professional, whether it's law, dentistry, medicine, whatever it is, you always want to be educated. And when I go on these, I learn more in a week than I would learn in months at home. Also, it's both ways. So I get a lot out of it. They get a lot out of it. They get their surgery done, and it's free and it's good. But it's also the most important reason we go, because it's a lot of fun. So here's one of our surgeons. She's a plastic surgeon from New Jersey, New York metro area, absolutely exhausted. She doesn't sleep the week. She's sleeping on the hard plastic boxes here. And then we moved her into the bus with all her stuff. I'm not going to go on to this. Basically, though, when we can go on these trips, we can provide surgery at 1% to 5% of what it costs here in the United States with the same degree of outcome and safety. So a lot of preparation goes into this. And my wife is a nurse, pediatric nurse, Lisa Shaw. I could not do it. She does almost all the preparation now because I can't do it. But here's the benefit. Here's our medical record. We don't have to use electronic records, which have a lot of deficiencies here in the United States. Eventually they'll get good, but they're not as good as an iPhone or an Apple or a Mac or anything like that. And so we make our own records. We make a little drawing of what we've done, and we able to escape all these regulations here in the United States, which do very, very little good and don't really improve outcome or our performance. Again, patients are very, very grateful. They give us what they can to express their appreciation. The crowd, this is what they use in some areas instead of taxis. You get a motorcycle, and they showed up to express their appreciation for us coming to our village. And I'll leave you with this thought. It's not Wakefield School, but you know, when kids in North America are forced to sit in classrooms all day, and if they move around, get excited, or make too much noise, they're given drugs to keep them quiet. Their main source of exercise is playing video games, and most of their food is fake and full of chemicals. That's terrible. We should take up donations for them. So that's it. I don't know if I can hear. I'm not going to touch anything. I'll listen.
Well, actually, it would be helpful if you stop share, if you can find that button.
Stop share. I did.
Look at that. First time. Excellent.
Okay.
So I'll ask one question first just to get things going, and then I'll throw it open to our Zoom visitors, giving preference to students. And again, if you can first use the raise the electronic hand button, that would be helpful for me. And if by some chance I'm not paying enough attention, you can wave and I'll try and find you that way. Dr. Shaw, so I'm on the board of Virginia Hospital Center in Arlington, and I've always been amazed. The physicians there have a medical brigade that goes down to Honduras and does the same sort of things that you're speaking about. And I'm astounded about how many people volunteer. Is that your experience as well? Or is it hard to get doctors and nurses and others to volunteer?
Quite the opposite, Stuart. We have a waiting list that we can't possibly meet. There's a hunger for this. I would say the Pediatric Orthopedic Society of North America has about 650 paying people that what I do. It's a very small specialty, very small. But I would say more than half of those people have done this at some point. What's a little more unusual is taking it on as an organizer. And I have to thank my wife for that. But no, it's very, very common, and more. There aren't enough places or groups like us to accommodate all the people that wish to go. And it's more now than before, because right now people are more conscious of the world at large, and that not everybody, most people in the world aren't fortunate like us and live with Western resources and modern resources. But there's also, we're crushed by the bureaucracy, and we can escape the bureaucracy but practice safely. And that's kind of a dream come true. And it's like you said, if life is short, the art is long. And if you find something that you like to do, it's not work.
It seems that when you mention communication issues, you're dealing with pediatric patients. Even where there isn't a language barrier, it's sometimes hard to communicate successfully with some of the younger patients that you may be involved with in the United States. That would be magnified by a significant amount when there's a language barrier on top of that.
You're absolutely right. And it raises a lot of ethical problems. And I have a whole literature of ethics, and we can talk about that sometime. But one case in particular, I remember we went to a place in Africa that was under resourced, and this girl was walking with one leg a foot shorter than the other, and it was bent and starting to hurt her, and she wanted us to fix it. So there's just no way we can fix it. So we brought in her aunt, who is a nurse in the country, and the whole family and interpreters. The only thing we could do was to amputate and provide a prosthesis, which would make her tall, and she make her a normal height because she was walking on a short leg. And we had to have 3 days of discussions, and she decided she wanted that. But then we had to figure out how we're going to provide a prosthesis, how we're going to get one to her, and how it's going to be fitted. You're absolutely right. So it's here in the United States, we call it the informed consent process.
Mhm.
And even that, as you know, as a dentist and a lawyer, is not always straightforward for everybody in English. So yes, we will draw diagrams. We'll make sure we have the proper interpreters and do the best we can. But ultimately it comes down, they trust us. They just trust us, which is extraordinary.
Well, I'm waiting for any questions to come in from the viewers. One interesting thing, a little off the point, when you and I first started talking, you mentioned that you had given a talk to the wilderness medicine group. Are there any parallels of treating in the wilderness and treating the sort of less developed areas of the world?
Well, sure. Yeah. Just basically being in a remote environment without your usual technology, without the technology that you're used to. So I think that was, and again, the Wilderness Society, they have a lot of people that are very interested in doing this because that's the same type of person that's attracted to it. So they wanted to know about this. So, and I'll just say to younger viewers, don't be intimidated by all this. You ask me questions. If you have questions, it may be a little intimidating hearing about surgery and stuff. So feel free to ask any question you like.
Well, if people don't start asking questions, I'm going to cold call them. That'll put them on the spot.
Yeah.
Yeah.
I see something in the chat. Let me see if I can read it here. Okay, it says, what medical specialties work best for our trips? And have I had any contact with Dr. Zimmerman? That's easy. I don't know that Dr. Zimmerman, but just because I don't know him doesn't mean really much at all. So, and then what type of specialties? You have to be broadly trained. So, well, medical doctors have been going forever, treating malaria, AIDS, giving shots and medications. But when you're going to do surgery, you need to make sure that they need what your specialty is. Like, you don't want to go there and do sports surgery. So the guys that want to come with me and young female orthopedic surgeons that are doing sports, I tell them, well, you can't come. You're too reliant on technology to do your ACL reconstructions. You need scopes and cameras. We don't have anything like that. So you can't be too dependent on technology.
Peter Larner, you have a question.
Hi there. I had a quick question for you. I'm wondering what you think some of the most important barriers to funding in terms of a public source for surgery, specifically internationally are.
Yeah, that's a super question. There's a whole literature on that. The question is about funding, and that's the bottom line. That's the bottom line to everything. I mean, that's the difference in going to countries. When we go, it's interesting. Like, there's only 30 orthopedic surgeons in the Congo for about 70 million people. But though any one of those guys knows more about anatomy and surgery and tech, so they have the skills. These are skilled people, and we have to be respectful. What they don't have is the budget. If they had the budget, you're exactly right. So that's the root of the entire problem, is budgeting. And then also, when people hear surgery, like, there's been the Bill Gates Foundation, other foundations going to African places to wipe out malaria and to tackle HIV/AIDS with millions and millions of dollars. But none of that goes to the most basic things. And I showed you the slide. Trauma and injuries kill way more people than all those things combined every year. But people think it's daunting. And we have to get past that barrier. There's a lot of people. So for your generation, I'd encourage you to work on that.
Thank you.
Here's another one. Would you recommend? Oh, here's two questions. How can a student interested in the field get their foot in the door during high school years? Well, the best thing is to find out who locally in your area, if you know anybody who's going on this, or, Paul was in the Peace Corps in Niger. That's where he met his bride. So now that's a little bit beyond high school. I think they require college education. Pretty sure they do. And now it's probably on hold with COVID, but it's going to come back. So anything like that, Okay, but also I've had high school students that have been relatives or good friends of people. Well, I've taken my own kids there, Guatemala. I make them work. They have to work, either painting or doing some. They can't work in the operating room, but they can work. And we'll get a job. That the key is planning, making sure ahead of time they know what they're going to have. We have equipment, so they're not sitting around doing nothing. So I would encourage you, if you know anybody in your area, you can look for nonprofits or churches. A lot of churches, people go. Maybe Wakefield School would like to do something someday, but that's how you get in. And then the other question is, would you recommend a career in medicine given the length of training and hassles of being a doctor? Well, that's a tough one. I have 4 kids. They've all seen how hard I work, and they say they don't want any part of that. So they're all in different activities and jobs and professions. So you have to really like it. You can't fake it. So you cannot fake it till you make it. It takes too long. So if you don't like even the process, I'd say don't do it. Get out when you can and find something else, because it just takes forever. But I'm very fortunate. I feel very fortunate because this is what I like to do. And it's good that people like different things in the world. Otherwise, we wouldn't have a society.
Let me follow up on that question. It seems that you practice medicine in an academic setting, at least today. What about different practice settings for medicine? Does that matter?
Yeah, it does. So actually, it's easier to do this if you're not in an academic setting, because if you're in a private practice setting, you're more in charge of your own schedule and getting time off to do that. In academics, you have so many different responsibilities. You have teaching responsibilities, you have clinical responsibilities, you have research responsibilities, and all those things come with a schedule and commitments. So if you just have one major commitment in private practice and you can control that, you can control your schedule. So that's why I would like to go to a place and work for a month or 6 weeks, but I can't do that. And I've given courses with the president of Doctors Without Borders, and but I haven't been able to serve because they require a 6-week minimum commitment, and I can't do that to my partners and the system I'm in. So I have to wait till I'm retired or semi-retired. So yeah, there's all kinds of ways to practice, but I'll let you this. Academics now has recognized the importance. So Peter Larner asked a question. And there are now just starting full-time academic positions that are supported by universities. So you would actually, we give up our pay. I have overhead that goes on while I'm gone, give up vacation and pay to do this. So I'm actually paying for it. Doesn't feel like that, but if you're an academic position, and now every major school and UVA, they're supporting these things. So I think that would be the way to look in the future and you pick a place or a country or an area and focus on that, make that your academic interest. You can do research, you can publish, and you can go serve.
A number of other chat questions have come up. Would you go into this line of work again if you had the opportunity? Let me kind of reform that question in a little different way. When you entered the practice of law, it was some time ago, and it seems that the practice of oh gosh, I'm getting myself confused. Medicine, right? Isn't that what you are?
Yeah.
Yes. And it seems that medical practice has changed in many different ways from the time that you first decided to go into it versus the way it's practiced now. So that may not be a fair question to you because the earth has shifted underneath you.
Yeah, and again, for the young people on the call, it's hard for me. People ask me for advice, young people, and I try to be as general and broad as I can because it's very difficult that things are changing so quickly. I will say my wife, who runs our Guatemala, does all the background work and the fundraising and the credentialing and the visas and the passport. She just had her shoulder replaced 2 weeks ago, and she went in at 5:30 in the morning, was home at noon. I mean, to me, that's a miracle. That's just unbelievable. I mean, and on the same day, I have a friend who's a retired surgeon. He's 90 years old, 90. He had his hip replaced in the morning and went home that evening. And he's walking. And to me, so there's a lot of good things happening for patients. So one person, I couldn't do that. I couldn't replace your shoulder or a hip or knee and have him go home the same day. So my skill set is narrower but it's applicable to what I do. In the future, I can't predict what's going to happen in the future, but I'm fortunate that I have broad training, broad background that enables me to do a lot of things. I worry if people are becoming too specialized. That's what I worry, that we're getting too specialized to the point where, people aren't going to be able to do except, the left shoulder, the right shoulder. That's what worries me. But clearly specialization overall has been better for patient care. It's to me as a surgeon, it's unbelievable what my colleagues are doing. 30 years after I trained.
Let's see. Dr. Nagel has actually said it's a fascinating presentation, and he's traveled through Guatemala, and he agrees with you. Did Guatemalan government require you to obtain a medical license to operate in their country?
Here's my wife right there. Do we have to get a license, or what do we get?
No, we get credentialed, so they give
Mm-hmm.
licensing that we have in the US. And basically we have every single person that comes has to get all their licensing, their current license notarized, and then we upload it to the website of the hospital that we're going to.
Yeah, the notarization is become a big thing, but yeah, things have come even in these limited resource countries. They're become a lot smarter, because they used to have people come down there and practice on people. These are people. Yeah. Again, it comes to the respect. These are real people. They have jobs. They have responsibilities. Their lives are a lot harder than ours. So the governments have become much more careful about who comes in. And that's a good thing, but of course it makes things difficult, but that's okay. We're fine with that. Yeah.
So we might have about 2 minutes left.
Yeah.
I'll entertain another question or two, but one that has already been asked. Usually we spend our time looking for donations for ourselves to Wakefield Country Day School. Is there an organization that if people wanted to support your efforts, they would be able to donate to? Perhaps you might be able to send us the name and we'll be able to circulate it among people that came to hear the talk.
Sure, I'd be happy to send you the link, but and I appreciate it. It's very, very kind of you, and very nice. I wouldn't want to detract from any gifts to the Wakefield School and your employment. Well, you're a volunteer, but I think Paul might get paid. I don't know. But anyway, it's called the Shalom Foundation, the Shalom Foundation.org. It's a 501c3. Again, we have all the paperwork for that. Based in Franklin, Tennessee, out of Nashville. I call it religious light. There's no religious threshold or anything. We treat everybody. I'm not particularly a religious person. There are some that are, but it's very, you would never know it, is my point. And mostly supported by country music stars initially get the stuff. Their names are on the 3 operating rooms. The head of the Country Music Association founded this 10 years ago, bought the hospital, got a lot of money. So now to keep it going, though, we rely on. I'll send you information, but thank you so much. That's very kind.
Paul, have you considered going to the Country Music Stars for donations for us? All right. One last chance for anybody to speak up.
It just occurred to me now. I like the idea.
We could have Paul sing and play the banjo, but that might be really distasteful.
All right. Well, on behalf of Wakefield Country Day School, let me thank you, Dr. Shaw, for a fascinating presentation. And the work that you do is incredible. So you may not be religious, but God bless you, I would say, for the work that you're doing. And
we have a lot of fun with it. We truly enjoy it, and it's a privilege and an honor. And thank you for this opportunity. And I wish everybody good luck.
All right. Well, then we will bring this evening to a close.
Brian, you're a hero to all of us.
Indeed.
Take care.
Brian, thank you again.
Bye-bye.
All right. Goodbye, everybody. Thank you so much for attending. We'll see you next time.